The use of a bougie to facilitate endotracheal intubation is an extremely useful technique. With the addition of this inexpensive and uncomplicated piece of equipment, a potentially difficult intubation can be performed with ease. It's essential that anyone involved in the process of endotracheal intubation, whether it be the proceduralist or an assistant, be aware of how this procedure occurs. In this video, we'll review the process of intubation with a bougie. A bougie is a semi-stiff plastic rod that's inserted into the trachea under direct vision using a laryngoscope. The bougie itself is often made of a plastic material, though some have the ability to be moulded into a desired shape. Most bougies are manufactured with a flicked-up end, as shown here, which allows it to flick up the epiglottis as it's inserted. Once inserted, the bougie is used to facilitate the railroading of the endotracheal tube into the airway. Ideally, the bougie and tube should be lubricated prior to use to assist in the passage of the tube. Some bougies have the added advantage of being hollow and can be used to deliver supplemental oxygen during the process. How useful this is remains unclear and probably unnecessarily adds complexity to the process. The process of bougie intubation is demonstrated here. The proceduralist, using a laryngoscope, inserts the bougie into the airway under direct vision. If the view of the larynx is suboptimal, the proper placement of the bougie can be confirmed by feeling the clicks as the bougie passes along the cartilages of the trachea. However, this is not always clearly felt. Additionally, if inserted into the esophagus, no resistance will be felt, in contrast to the eventual resistance felt when the bougie reaches a bronchus if correctly inserted. Once in place, the proceduralist secures the bougie in position to avoid dislodgement. The laryngoscope should remain in place. The airway assistant then loads the tube onto the bougie. Care should be taken as the bougie reaches the connector, as it's a common place for it to become snagged. Once the ETT is fully loaded, the airway assistant secures the bougie, allowing the proceduralist to advance the ETT into the patient's upper airway. The laryngoscope is used to gently move the subglottic tissues upwards to allow the passage of the tube. As the tube reaches the glottis, the tip may be inclined to snag on the right vocal cord. Using a corkscrew action in an anti-clockwise direction, the tip can be manipulated into the airway and the tube advanced. Care should be taken to avoid too deep an intubation and the depth from the teeth noted. The bougie is then removed, endotracheal positioning confirmed, and the tube secured in the usual fashion. Bougie intubation is useful in many more challenging airways when it might be difficult to directly intubate the trachea. This includes patients who are in unfavourable positions, such as cervical spine injuries, in unfavourable Mallampati-graded airways, or when airway secretions or blood prevent an ideal view. The bougie allows for intubation even when the glottis is completely invisible. Using the epiglottis as a guide, running the tip along its undersurface, the glottis can readily be intubated. There are few disadvantages to this method. The procedure may take fractionally longer than conventional intubation, though this is rarely significant. Inadvertent endobronchial intubation and possibly airway trauma are the most important complications. In this video, we have reviewed the important airway skill of bougie intubation. This process involves the insertion of a semi-stiff catheter into the airway that allows an endotracheal tube to be railroaded into the airway. Avoidance of endobronchial intubation is important.